Okay, our next speaker is Antonio Zadra, a PhD in clinical psychology from McGill, postdoc fellow with Medical Research Council of Canada at the, I can't speak French, so we'll just say Sleep and Chronobiology Research Center in Montreal, and he will speak on sleepwalking and consciousness.
All right, so I'm going to be talking to you today about sleepwalking, somnambulism, and particularly two aspects of it. That is, what do we know about the phenomenological contents of sleepwalking episodes? And second, what are the EEG correlates that we can observe in the sleep lab when we capture episodes in the lab? So first of all, sleepwalking is a non-REM sleep parasomnia. It's typically characterized by mental disorientation, various types of motor behaviors, misperception, relative unresponsiveness to external stimuli, and variable retrograde amnesia. I put variable because in even some diagnostic texts, it says that there's a complete amnesia for the episodes, retrograde amnesia. And one thing that we'll be showing you is that that is clearly not the case, as a significant proportion of sleepwalkers are able to recall at least parts of their episodes. Now, the actual episodes themselves, which can last from anywhere from a couple of seconds to dozens of minutes, typically arise from incomplete arousals out of slow-wave sleep, and about 20% of cases out of stage 2 sleep. So it's not just limited to slow-wave sleep. The types of behaviors we can observe also vary. They vary in terms of emotional expression. The patient can be either agitated or very calm. And in terms of the motor manifestations, they can be clumsy, simple behaviors, just sitting up in bed, pointing at a wall, talking, sometimes making sense or not, fingering the bed sheets, and so on. But they can also be much more complex and elaborate, rearranging furniture, cooking, trying to eat things, getting dressed, playing a musical instrument. I'm taking for granted here that you can play while you're awake. It's not just a newfound ability in your sleep, which would be cool, but that's not the case. And sleepwalking is not a benign condition. It often leads to injury, either to the sleeper or to bed partners. Some sleepwalkers can damage furniture in their environments. One patient we saw about a few months ago, when we asked him what brought him in, he said, well, it's the third TV set that I throw to an intruder, which isn't there, and it's getting damn expensive. So there's different reasons they can come in, but the point being, this is not necessarily just a benign, sort of amusing condition. And so that's what brings most people to the clinic, is either they've injured themselves or injured others. However, relatively little is known about the mental contents that accompany these episodes. In terms of also what do we know about what's happening in the brain during episodes, there's early studies done in the 60s, primarily in a small group of children, found that the EEG recordings during the episodes were characterized by a combination of alpha, theta, and some delta frequencies, but never any evidence of clear wakefulness during the episodes. In '98, Schenk and his colleagues in Minnesota conducted a systematic review of over 250 behavioral, non-behavioral arousals out of slow-wave sleep in 38 adults that either had injurious sleepwalking or sleep terrors. And basically what they were able to outline were 3 post-arousal EEG patterns that characterized the first 10 seconds of episodes. Pattern 1 shows a diffuse rhythmic synchronous delta activity, so 4 hertz or less on the tracings. Second pattern, diffuse and irregular moderate to high voltage delta and theta activity, intermixed with some faster frequencies. And the third pattern was prominent alpha and beta activity. However, these patterns have never been examined by another group other than the one in Minnesota, and they've never been assessed in terms of also different forms of event complexity, or do they also occur in events that arise out of stage 2 sleep. So what I'm presenting to you today then are 2 complementary studies, if you want. One touching on the phenomenological aspects of sleepwalking, and second, looking at the distribution of these EEG patterns with respect to episodes that we've collected in the lab. So turning to the phenomenological aspects, I'm going to present you findings from clinical cases that we've collected in our lab at the Sleep Disorder Center. An ongoing study where all the sleepwalkers that come to our lab complete an elaborate questionnaire that looks at their history, precipitating factors, and so on. But there's a whole section dealing with various phenomenological aspects of their episodes, and I'll be presenting to you some of our findings on that. And finally, I'll show you some recent episodes we've collected in our laboratory and look at what kind of sleep mentation these patients are able to report in the morning following these episodes. So first, a few clinical cases. The first one on the top left is a woman who was found by her bed partner. She's scratching at the walls of her bedroom, and she's tearing off all of the wallpaper, not because it's horrible, but because she's hearing children on the other side, and they are screaming for help. There are no children on the other side of the wall. This is just a hallucinatory process, but this is the content of her episode. The one with the dog looking out of the bathtub, an episode from a 28-year-old male who, during his episodes, in quotation marks, wakes up. His wife also wakes up. He does have a dog, and his dog is lying, sleeping quietly on his bed. He grabs the dog by the neck, immediately gets up, goes to the washroom, turns on the water, takes the shower head, and rinses the dog. Why? Well, because during his episode, the dog, which he saw correctly, but was on fire. And so he was actually trying to extinguish the fire on the dog. The bottom left was not fun for the dog, but at least his wife wasn't on fire, which probably would have been worse. The bottom left shot is someone who wakes up during the night, grabs the bed, his girlfriend is in it as well, and starts moving the bed away from the wall, and then starts moving the dresser away from the wall. Again, his girlfriend, not too pleased being woken up in this fashion, asks her boyfriend what's going on, and he said, "We got to move all the furniture, we got to move all the furniture, the train is coming." And so she explained to him that they live on a third-floor apartment, and there's no trains, zero effect. He's still in a panic mode, removing all of the furniture. And then she's trying to point out, well, look, which way is the train going to be coming from? Again, zero effect. He's trying to move everything and telling her to get out of bed because she's going to be hit by the train. She does get out of bed, and she tells her boyfriend, look, if the train is coming, where are the train tracks? And so at this point, he kneels down and puts his hand on the ground, and he goes, you're right, no train tracks. So third floor apartment, zero, but no train tracks in his bedrooms. That makes him realize that maybe he's having one of his episodes and that there is no immediate danger. And the last case, one that our group published a while back, a woman wakes up screaming. She tells her husband there's an intruder in the corner of the room. The husband gets up, turns on the lights, tells her, see, there's no one there. She still maintains that the intruder is hiding. He goes to the corner of the room, says, see, no one here. She tells him maybe he went to another room. He goes, fine, I'm going to go to another room. He does that. While he's in the other room, he hears his wife scream. She jumps out of the window, falls 7 meters, about 23 feet, breaks both of her legs. We've also had someone else who jumped out of the window, fell on a steel picket fence, and the fence actually went through his legs. Luckily, he didn't die. It wasn't his spine. Again, so these are extreme cases, but it illustrates the harm potential associated with this. So what these clinical observations suggest is, one, these events are often associated with various forms of hallucinations, which aren't just visual, but can also be auditory. The sleep mentation that these patients experience contributes to how the somnambulism, the episodes themselves will unfold. And these patients are able to recall at least parts of their episodes on occasion. I mentioned that now it's been several years. All the patients who see at our clinic complete thorough assessments, but also this questionnaire that contains a fairly long section on various aspects of their episodes. So I'm presenting to you data today on the 94 most recent patients that we've seen, 43 men, 51 women, a mean age of about 33. All of them were referred by their family physician to our clinic for primary sleepwalking. The vast majority reports that their sleepwalking began during childhood or adolescence, which is a typical feature. All of them had a standard polysomnography at our lab. All met the most recent International Classification of Sleep Disorders criteria for sleepwalking. And here are some of the results on some questions, just descriptive results on what they tell us. First of all, we have 62% of our patients who tell us that they remember their episodes, at least sometimes, often, or always. Again, we're a far cry from the complete retrograde amnesia that in many texts says characterize somnambulism. The patients, over 80% say they will, at least on occasion, sometimes, often, or always remember sleep mentation, that is a mental content that accompanied their episodes. When we ask them, do you ever remember your specific behaviors that you did during episodes? Again, over half will say that at least on occasions, or often or always, they do. Do you remember perceptual elements? That is, you remember seeing things in your bedroom, like the example of before, the dog and so on, your bed partner. And again, 3/4 of the people here say, yes, I do remember perceptual elements from my actual environment that got incorporated or were part of my episode. And finally, is there an emotional content to the episodes? Again, here about 75% do report that emotions are present during the episodes, and the most commonly reported ones are fear, panic, confusion, anger, frustration, helplessness. Of course, as you'll notice that positive emotions such as joy do not figure here. Finally, as I mentioned, we've also been maybe I didn't mention it, we've also been investigating episodes in the laboratory. We've also developed diagnostic techniques to induce episodes in the lab. These involve the presentation of auditory stimuli during slow-wave sleep, typically, combined with sleep deprivation, which puts pressure on slow-wave sleep, and these people, slow-wave sleep generating mechanisms are already quite fragile. But we also have many episodes that occur spontaneously in the lab. And so I'm going to show you 4 recent examples of episodes that we recorded in the lab, together with the description of the sleep mentation that the patients reported for these. This is a francophone patient. He's a new dad, and if the volume is working, you're going to hear him say, for those of you who speak French, je l'ai échappé, which means I dropped him, I dropped him. And what he will tell us later is that he, during his episode, he believes that he is sleeping with his newborn son and that he dropped him during the night. And so he's frantically trying to look for him on the side of the bed, under his pillow, and he's also thinking, my wife's going to kill me because here she lets me sleep with the newborn and I've lost him. So this is his episode.
Oh, l'échappé. Je l'ai échappé. Hey. Vite. Hey. Ah merde, elle est où? Vite. Aidez-moi, s'il vous plaît. Est-ce que tu la supportes? Mais France, c'est déjà?
Well, we never complain of pain, but when you get out of bed like that and you have your electrodes pulling on your scalp because they're well tied with a collodion, that's kind of a painful condition. Here he hears a voice and he thinks there's, again, someone in his room and he's not quite sure what's going on, so he wants to get out. Here's someone who, if I can get it to work, believes that there's insects on his bed in the sleep lab, and our sleep lab is pretty clean. And he's going to be trying to kick all the bugs and mice that are on his bed away.
No. Hey! What the move? What the? Oh, shit.
And finally, the last one is an agitated episode. Resembles a lot like a sleep terror, and actually sleep terrors and agitated sleepwalking can be difficult to distinguish. You have her EEG tracing on the side, so you see there's really high amplitude delta activity. She's in stage 4 sleep. In her episode, which you're going to hear her scream, she believes she has a snake around her neck, which is strangling her. Not fun. All right, so that's a little bit for the phenomenology. Now, what do we know when we're looking at the EEG signals that accompany these events? So I'm going to present you here some summary data on 50 events that we've recorded in our lab, 35 from slow wave sleep, 15 from stage 2 sleep. EEG tracings were evaluated by a certified electroencephalographer, and they were scored according to our previously established and published criteria. We also scored each episode on a scale that exists for episode complexity that has good inter-rater reliability. Basically goes from level 1, simple behaviors, playing with the bed sheets, electrodes, wires, and so on. Person is usually confused. Type 2, more complex behaviors, sitting up in bed, resting on one's knees, trying to get out of bed. Type 3 is any event where the person succeeds in getting out of bed. Again, what we find here across all of these episodes is they can pretty much all be characterized according to 3 standard EEG patterns, not unlike what was described by Schenk and his colleagues. The first one, again, these diffuse rhythmic synchronous delta activities, less than 4 Hertz, that we see only in stage 4 and that accompany simple episodes. We have diffuse moderate to high voltage delta and theta activity intermixed with some other frequencies, alpha and beta. And the third one is prominent alpha and beta activity, at times intermixed with moderate voltage theta activity. And one thing that is of particular interest is that the delta waves usually have 75 microvolts or more, which you only see during slow wave sleep. We notice in about 50% of all episodes during slow wave sleep and 20% of the events recorded out of stage 2 sleep. In none of these 50 episodes have we found any evidence of a complete awakening. There's also patterns 2 and 3 are the only ones that accompany episodes out of stage 2 sleep. And pattern 1, the one with synchronous delta activity, usually is only seen out of slow wave sleep and accompanies simple behaviors rather than complex ones. Here's an example of where you have yellow as the episode onset. So here's an example of EEG pattern 1 in a 19-year-old male. And you can see that the delta activity is more prominent in the anterior regions. Here's an example of pattern 2 with irregular delta and theta activity in a 23-year-old woman. Now, a question that arises is, are the sleepwalkers awake or are they asleep? And another question sometimes people ask is, are they dreaming? So first of all, if we look at the behavioral manifestations during the events, most patients, not most, actually all patients have their eyes open during their episodes. And they not only are able to, with varying degrees of success, navigate in their environment, especially if it's a known environment, but they interact verbally with other persons in the room. It might not make much sense, but they can still converse with them. The sleepwalker's environment is incorporated into their episode. Their bedroom, their bed, characters, and so on. They might misinterpret things. The little red dot on the VCR might become a laser pointer, for instance, but they still are in contact with their immediate environment. For these reasons, we like to conceptualize the sleep mentation more as a form of a hallucinatory process than dreaming per se. And then in terms of the EEG, well, these EEG patterns that we see are not indicative of wakefulness, nor are they indicative of typical sleep. And so they really support an idea where there's a dissociation between cortical and motor activities. And we also see regional EEG dissociation, where you have some alpha activity in posterior regions of the brain and slow wave activity, which usually characterizes sleep, in frontal regions. We are conducting now a SPECT-based brain imaging study on sleepwalkers, both that characterize their slow-wave sleep, their wakefulness, and their episodes. There is a single case study published in the literature using SPECT during a 16-year-old man's episode recorded in the laboratory. That was in Lancet by Claudio Bassetti. And basically what they found was an increase of 25% in regional cerebral blood flow in the posterior cingulate and anterior cerebellum compared to slow-wave sleep, which leads them to suggest that the cingulate cortex modulates the behaviors in response to emotional processes, and also decrease in regional cerebral blood flow in other areas compared to wakefulness, which is a pattern that we usually only observe in normal slow-wave sleep. And so these data, the brain imaging and the EEG data, suggest to us that the brain is at least indeed asleep, or at least partially asleep during these episodes. Now, what I've hoped to have shown you is that sleepwalking should not be characterized in terms of automatic behaviors, nor by retrograde amnesias. The behaviors that many patients will display are construed by most of them as being motivated by an intrinsic sense of urgency or logic. It might not be logical while you're awake. For instance, the example with the train that's about to hit, but it does make sense to the person during the episode. And when available, these mental contents seem to be broadly consistent with the behaviors that you observe. Now, this shouldn't be taken that the mental contents of the sleep mentation precipitates the episodes, but it certainly helps drive them and influences how they unfold. And that is really of interest to us. And the same thing for the hallucinatory processes. So to conclude, I think that our results here clearly indicate that perceptual, cognitive, affective dimensions play an important role in the subjective experience of sleepwalking. We're continuing to investigate this at different levels with brain imaging, questionnaires, and clinical case reports. And our data, I didn't have time to show you our pilot SPECT data, but definitely our EEG data that is quite robust thus far, supports the notion that sleepwalking is a dissociative state where you have motor arousal and persistent mind sleep. And wakefulness and sleep are not a dichotomous black and white thing. There's a lot of gray zones, just like when you fall asleep, it's not you're immediately asleep, there's a transition period. And sleepwalkers have trouble going from slow wave sleep to wakefulness, and they get stuck in this gray zone where they are predisposed to have episodes. And so maybe at a future conference we can talk, I'll be able to present to you more on our brain imaging studies during actual episodes recorded in our laboratory. And I just want to thank different members of our research team which deal with the patients when they're screaming and having episodes in the lab, among other things. Thank you.
Time for a couple of questions. Can I ask, do we know for sure that they're having subjective experience? Could they be zombies, autopilot?
Well, they could be zombies and autopilots. We haven't checked that out yet because we don't have a good test for that. But when they wake up in the morning, they tell us, yeah, I remember I had an episode last night, and this is what was going through my mind. So they're lying zombies then.
Over here.
Yeah, and we don't question them in the lab. We don't question them immediately after the episodes. They typically fall back asleep, and it's only in the morning that we ask them, do you remember having an episode, and so on, unless in the extreme cases where we have to physically intervene so they don't harm themselves.
I mean, it could be implicit memory, so they might not need to lie and still be zombies, but...
Could be.
Over there.
Yes. Do any of your patients have their condition caused or exacerbated by drug and alcohol abuse?
Not alcohol abuse. Certain categories of drugs can induce somnambulism, but these are not in people who are predisposed to somnambulism. Right, people who have, there's a very strong genetic component to somnambulism, which we're also investigating. And so these people usually have been sleepwalkers since earlier mid-childhood.
Okay.
Over there. Please be brief.
Methodologically, with the EEG, about all you can pick up is cortical or maybe thalamocortical in this case. And I'm wondering, some of this recent research from Scheinen and Turku in Finland, you're seeing people jump around. Obviously, their basal ganglia and all kinds of things are involved in this. Do you think their research sheds any light on what might be going on in somnambulism?
I'm not quite sure, only because, first of all, when we're looking at the EEG, as correctly pointed out, it's a fairly gross measure and a surface measure of activity. And then I think that in sleep, there's a lot of, if you want, atypical events that can take place, and that the underlying physical substrates really vary a lot from condition to condition. And even sleepwalking is far from being a homogeneous event. Like I said, I think probably when we get more information, the very agitated episodes versus the more benign ones probably have very different underlying substrates. So it definitely helps us get a better idea maybe of what's going on, but it's probably not just one pattern, one thing.
Ned.
My phone. You mentioned frontoparietal suppression, and I'm wondering whether that includes the dorsolateral prefrontal cortex. And my reason for asking is, assuming the answer to Stuart's question is yes, these people are having genuine experiences, this would be a test case for the higher order thought picture of consciousness, because if there's suppression of dorsolateral prefrontal cortex, that makes it less likely that they're having thoughts, but they're having conscious experiences, so that seems to be irrelevant.
Well, there's some pilot, in the study published, no. And again, that was a single case study that was then compared to normative data for wakefulness and slow wave sleep. And so we don't see it there. We do have pilot data.
Wait a minute, you don't see dorsolateral prefrontal cortex suppression?
Well, not to the extent where it would be significant, where you could see it compared to the normative data. Again, this is just the study by Bassetti is a single episode, right? That's all. And so it's very hard then to start saying, is this a significant decrease or what do you see? Because you have no real comparison basis. And it's not even compared to the same 16-year-old. It's compared to normative adult data. In our own pilot data, the answer to me so far looking at it would be yes, we do see that suppression.
Yeah, thanks for your talk. I just was wondering about reality testing functions and thinking about the episode with the guy with the train tracks.
Yeah.
How he was responsive to not to being on the third floor apartments, but checking out the train tracks. If you've seen other anecdotes pointing to what kind of cues you might respond to, I can test this one. Or
it really varies, and maybe I'll end with maybe one of the more fascinating cases with someone who had a lot of sleepwalking. His wife was really interested in his episodes. And so he'd often do tests asking his wife to tell him X, Y, and so on to see what he would do. But he had one episode whereby he really thought there was a gas that was going to kill them emanating into the room. And he woke up his wife and he said, we got to get out here, there's a gas. And then he tells her, look, I know I have sleepwalking episodes. This is not one of them. We have to get out right now. And so this is really rare, but there's critical thinking going on, and so he is aware that he sometimes does these foolish things, but he must be taken seriously this time or they're going to die.
Really quick question. You're really great at measuring and recording what's going on here, but do you have anything you can offer to these people, any therapies?
Self-hypnosis is what works best for a wide variety of these patients. And now hypnosis means different things to different people. Basically, relaxation exercises with guided imagery. Usually a couple sessions, they learn it themselves, they practice it at home, works well. There's pharmacotherapy that can be helpful as well, but we try to shy away from that because there's usually a rebound effect on their episodes once the medication is stopped.
Last question over here. He was waiting, then we got to cut it off.
Yeah, so you mentioned various types of associations with people who sleepwalk. I was wondering if there's, in your questionnaire, any associations with your work or with other work about childhood environments or even maybe worldview type associations. So like people with maybe a particular worldview or with a particular childhood environment maybe are more or less likely to sleepwalk or have certain types of sleepwalking experiences, like fearful ones as opposed to different types.
No, you can have some trauma-related sleepwalking, parasomnias, but in terms of these more general things, no. Not that I'm aware of.
All right, let's thank Antonio for a fascinating talk. Thank you very much.